Today I'm going to present you the study that we conducted, the WBMT, the consortium, the World Bone Marrow Transplantation, looking at the baseline characteristics and clinical outcomes in newly diagnosed multiple myeloma patients undergoing upfront autologous stem cell transplantation. So this is, in fact, the first attempt to collect myeloma baseline characteristics and transplant outcome from different international registries, mostly 7 registries. So we are including, this is a retrospective study, including newly diagnosed myeloma patients, adults, who were diagnosed between 2013 and 2017 and got an upfront, not delayed, upfront autologous stem cell transplantation. The endpoints, the primary endpoints are overall survival and non-relapse mortality, and secondary relapse incidence and progression-free survival. So we collected data from 7 registries, and we got information, data from, as you can see, over 61,000 myeloma patients from over 600 centers. The median follow-up is 41 months of the study. This is mostly data coming from EBMT, but also CIBMTR and Asia Pacific BMT, Eastern Mediterranean BMT, and Latin American BMT, and a smaller registry from Canada, from Ottawa. You can see it here where the data are coming from. So 2/3 are from the EBMT, 61% exactly. 1/4 from the CIBMTR, 26%. And then from Asia Pacific BMT, that includes Japan, Malaysia, Taiwan, and Australia, New Zealand, and smaller registries from Latin America, Eastern Mediterranean bone marrow transplantation, and a smaller one in Canada from in Ottawa. In terms of statistics, we use standard statistical methods. As you will see, when we proceeded to the multivariate analysis, because we have a high amount of missing values for important prognostic factors such as the ISS score, the cytogenetic risk score, and the comorbidity index to transplant, we performed 2 different multivariate analyses, one covering all the patients, and another one a smaller subset of patients, but with full data set. So this is the baseline characteristics of the whole population. We had 16% from Asia, 11% African American. These are relatively young patients, around 60 years of age. In terms of myeloma phenotype, mostly half of them are IgG, but the second most common is light chain, and then IgA. As you can see, ISS score is missing in 46%, and it is relatively well balanced between ISS 1, 2, and 3. Cytogenetic risk also is missing in a little bit more than 50%. And for the data that we have, 70% were standard risk. Karnofsky score is shown here. The comorbidity index for a transplant is missing in 28%. However, we have almost full data for disease status at transplant. So as This has, because it's a registry study, we don't have the induction regimen that were given to the myeloma patients, but we do have the disease at transplant, sorry. Most of the patients, 82% got melphalan 200 milligram per meter square, only 14% 140. The Tandem transplant was performed in 7%. The source of autologous stem cell was mostly peripheral blood, and we have very few data on maintenance treatment post autologous stem cell transplantation. About 9% available, and for these patients, 58% got lenalidomide maintenance. In terms of outcome, the median overall survival is a little bit higher than 7 years. In terms of progression-free survival, the median PFS is around 3 years. The non-relapse mortality is very low, around 1%, and the relapse incidence is around 16% at 1 year. In the multivariate analysis, the first analysis focusing on most of the patients, but with missing data. There is a slight benefit in favor of female compared to male, mostly to control the myeloma disease, no difference in terms of non-relapse mortality. The year of transplant, the young, earlier years have a strong impact to control the disease, as you can see. Much better results in terms of overall survival, PFS, and relapse. The disease status at transplant is very predictive of outcome, both OS, PFS, and relapse, and also the non-relapse mortality. The Karnofsky score is also very predictive for the outcome. Outcome is a little bit worse for IgA compared to IgG, and to some extent, light chain myeloma is a little bit also detrimental. In terms of conditioning regimen, melphalan 200 is better than melphalan 100, but there may be a bias with patients who got the melphalan 140 were probably had more comorbidities. Now, if we include, if we focus only on patients who have all the data, and that includes the ISS, the cytogenetic, and the HCT comorbidity index, we have similar results. And as you can see, ISS, cytogenetic, and to some extent, the comorbidity index are strongly prognostic for the outcomes. ISS and cytogenetic, both for the disease control and the overall survival, but also the non-relapse mortality for the ISS, and the comorbidity index is very strong for toxicity, non-relapse mortality, and in the end, the overall survival. So in this first part of the results, we can conclude that first, this is the largest study of real-world, real-life, worldwide autologous stem cell transplantation outcomes in multiple myeloma. As we know, this is a confirmation. It's a very safe procedure with around 1% of non-relapse mortality at 1 year. And this is worldwide. The relapse incidence is 16% at 1 year, median PFS 3 years, median OS 7 years. We confirmed the main unfavorable prognostic factors, such as older age, suboptimal response at transplant, low comorbidity, Karnofsky score, IgA phenotype, high ISS, adverse cytogenetics, and high HCT comorbidity index. In the second part, we compared the 7 different registries that we had collected. First, you can see that there is an increased number of auto transplant by year from between the year 2013 to 2017. In the 2 biggest registries, the EBMT and the CIBMTR, it's increasing. And it's also increasing in the other registries. In terms of age, there are some important differences. The median age we mentioned is around 60 years. However, we do have patients transplanted above the age of 70, and this is mostly done in North America. As you can see, around 10% of these patients come from the CIBMTR, and much less in Europe, 3.5%. On the opposite, we have registries with much younger patients, such as the Eastern Mediterranean BMT and the Latin American BMT, with the median age in Eastern Mediterranean BMT of 53 years compared to 60 in the whole population. The comorbidity index at transplant is also quite different from registries to registries, as you can see here. The lowest being in Malaysia, 3.8%. Some patients, we mentioned, got tandem transplants, 7%, and this is mostly done in Europe. As you can see, 10% of transplanted patients have a tandem in Europe, while it's only 1.3% in North America. We found also important differences in terms of cytogenetics, with a global high risk around 30%, but only 5% in Eastern Mediterranean BMT and 62% in Ottawa. ISS score is also quite different. In Australia, New Zealand, low 24% and high 45% in Latin America. Karnofsky score is also quite different from registry to registry. IgA phenotype, with an adverse prognostic factor, is low in the Eastern Mediterranean BMT, 13%, and almost twice as high in Ottawa. And the response status at transplant, with the VGPR or better of 38% in the whole population, and it's much higher in Latin America, BMT, where there is probably a selection of the patients there, with 76% having a transplant status of VGPR or better. Now, if we look at the overall survival in the different registries, you can see that there are some differences, mostly at 3 years. Most of the overall survivals are around 80% and above, but 2-3 registries, the Eastern Mediterranean, Taiwan, Malaysia, is less than 80%. This is similar with progression-free survival. Non-relapse mortality is extremely low worldwide. And the relapse incidence also is different from registry to registry, as you can see here, from 12% in Latin America to 24% in Malaysia. So, in conclusion, relapse incidence, PFS, and overall survival was markedly different between registries. It may be related to differences in baseline prognostic factors, as we have seen in clearly, but also to access to healthcare and new myeloma drugs and specifically maintenance treatment availability post transplantation. So we are currently working on this topic and try to find to better define the why there are differences between registries between different parts of the world. And we are also conducting sub-studies addressing specifically the issue of age, race, ethnicity, and gender. Thank you very much for your attention.